In this video, we are going to look at the anatomy of the heart, discuss about aortic valve and discuss about the aortic valve disease by name aortic stenosis. If this valve is not going to function, that means if it is going to be echocardiogram is nothing but the ultrasonogram of your heart. The cause of aortic valve is wear and tear mechanism is the most important cause, that is degenerative aortic valve disease, followed by rheumatic heart disease where Hi everyone, this is Dr. S. Nagendra Bhupati, Professor of Cardiology at Sri Ramachandra Medical College and Consultant Cardiologist at Dr. Bhupati's Heart Care, Kodambakam, Chennai. In this video, we are going to look at the anatomy of the heart, discuss about aortic valve and discuss about the aortic valve disease by name aortic stenosis in detail. So, heart has got 4 chambers. This is our heart. Okay, it's going to lie beneath the breastbone, right atrium, right ventricle, left atrium and left ventricle. The blood comes to the left ventricle, oxygenated blood is ejected by the left ventricle into the aorta through a gatekeeper valve called as aortic valve. If this valve is not going to function, that means if it is going to be a stenotic valve, that is restricted opening, or if it is going to be a leaky valve, that is the blood goes into the aorta but comes back again into the left ventricle, we call them as aortic stenosis and aortic regurgitation respectively. Going on, we will be looking at the aortic stenosis alone in this particular video. Aortic stenosis is quite common as we grow older and older. It affects 2 to 5% of older adults and more than 10% of adults after 80 years are supposed to have some form of aortic stenosis. We classify aortic stenosis based on several echocardiographic criteria. Echocardiogram is nothing but the ultrasonogram of your heart by means of the area reduction, by means of the velocity of the blood across the valve and measuring the gradient, pressure gradients across the valve. We classify the aortic stenosis into mild, moderate and severe form. Especially if the patients are having some symptoms in the severe form, we treat them. If you look at this particular figure, this is the normal aortic valve where the valve leaflets are quite glistening in structure. This is a diseased aortic valve where a lot of calciums are sedimented on the leaflet with restricted motion. The cause of aortic valve is wear and tear mechanism is the most important cause, that is degenerative aortic valve disease, followed by rheumatic heart disease where people who get rheumatic fever at the early childhood develop this problem at the age of 5th decade or 6th decade. Another problem for aortic stenosis is congenital aortic valve disease. That is in general, as shown in the figure, the valve has got 3 leaflets, 1, 2 and 3. Some of these patients may not be having 3 leaflets, they may be having 2 leaflets, which we call it as bicuspid aortic valve, which is not very uncommon. It's quite common in Indian subset of patients, especially between age 60 to 80 years. As the age group increases towards 80, we see more often a degenerative wear and tear related aortic valve disease rather than congenital bicuspid aortic valve disease. How does this disease manifest in individuals? The most common symptoms in such patients is breathlessness, that is dyspnea. In addition to that, patient can also have chest pain, loss of consciousness or palpitations. There are various reasons for those symptoms. We know this particular disease since 1960. We diagnose this problem by clinical examination of the heart where we will be able to hear audible murmur in the chest. By doing echocardiogram, by using ultrasonogram waves, we will be able to see the heart clearly and we can identify how exactly the disease severity is. Very rarely, patient may also need a cardiac catheterization if there is going to be a discordance between the symptoms of the patient and the echocardiographic findings. We classify the aortic stenosis based on risk factors, intensity of stenosis and symptoms from stage A to stage D. If you look at this particular chart, this is quite old chart available since 1960s. So, if the patient doesn't have any symptom, they will do quite good. Once they develop symptoms, there will be significant deterioration in their survival. So, it is very essential to identify the sweet spot of such patients who have got symptoms and severe aortic stenosis and treat them properly. In contrary to the myth that this disease, if not treated, if the patient has developed heart failure, has got much worse prognosis than many other cancers. So, we have to be aware of the same fact too. Unfortunately, there is no medical therapy for the same at this point of time. No medicine works. It's a mechanical problem. It has to be started in a mechanical way. Till 2002, it was treated by means of surgery where we opened the heart, stop the heart, remove the old diseased leaflet and put a new valve. This is called a surgical aortic valve replacement. Since 2002, we are able to do it percutaneously. This is the first person by name Professor Alain Crivier who did it in France. And since then, millions of patients have undergone this particular therapy. So it involves if a patient has got symptoms, once the echocardiography is done, this is identified, then we get a CT angiogram to look at the feasibility of getting the procedure done transcatheterally and then proceed with the same. In this particular video, we will be discussing about transcatheter aortic valve replacement and transcatheter aortic valve implantation. If you look at this particular video, you are able to see a diseased aortic valve which is not opening properly with significant amount of calcification, and it is a tricuspid, tri-leaflet aortic valve. In transcatheter aortic valve therapy, we go through a wet artery called as transfemoral artery. We put a long wire, go from the femoral artery all the way to the aorta. We cross the aorta, enter into the left ventricle through the aortic valve. Through this particular valve, we take a balloon to open the valve so as to create a space for the valve to enter. This is called as pre-dilatation. By doing this, we are ensuring that there is enough space for the valve to sit in. Once this is done, we take the valve. There are two types of valve. What we are seeing is the balloon expandable valve. There is another valve called a self-expanding valve. In this video, the valve is taken across the aortic arch through the aortic valve into the left ventricle. Once the position of the valve is confirmed by means of an angiogram, we deploy the valve by inflating the balloon using rapid pacing protocol. After that, the balloon is removed and the wire is removed. The valve is sitting quite nicely. The old leaflet is pushed back by the stent frame. You can appreciate a good functioning new aortic valve in this particular patient. This is called as transcatheter aortic valve implantation. These days, these procedures are being considered in individuals who are more than 65 if they are surgically kind of intermediate or high risk. Especially in individuals who are more than 75 years, this is the therapy of choice. Usually, after getting a CT scan done, if it is technically feasible, we admit the patient one day before the procedure where the heart team that includes cardiovascular anesthesiologist, cardiothoracic surgeon, interventional cardiologist, see the patient and discuss the procedure with the patient, and on the next day we do the procedure as described in the previous video, and then to next day if everything goes well, which is the norm, usually the patient goes home. So patient has got less pain, less hospitalization. It has been proven to be equivalent to surgery if they are going to have a low risk. If the patient is very high risk for surgery, it has been shown to be superior to surgery. And once the procedure is done, patient will be on regular drugs. In addition to that, he will be on single antiplatelet, either an aspirin or a clopidogrel. After that, we do a repeat echocardiogram after a month and annual screening echocardiogram after 1 year. This is the protocol what we follow in following such patients. Thank you.